Welcome to the Chapter 10 Airway Management video lecture. I am Instructor Morris, and I'll be presenting the information to you guys today. I think we can pretty much say that Chapter 7, 8, and 10 are some of the most important chapters that you will be exposed to. You will take this information and build your foundation. I have been a paramedic for over 25 years, and I continuously use skill sets that I developed in EMT and paramedic school to maintain an airway. So it's again, a very important chapter. So let's dive right into it and get started. Let's get some of the objectives, because there's lots of objectives in this chapter. Okay, let's excuse me, let's do the case study. You're on unit 112 and you're dispatched to the Twilight Bar at 59 South Market Street for an unresponsive male patient. All right, and just kind of let me try to move myself over a little bit, maybe. Maybe that'll be better. I don't know, better or worse. All right, we'll see if that works. All right, so going to the Twilight Bar, 59 South Market Street for an unresponsive male. So we're getting this call for a person unresponsive. Some of the things, in the dispatch areas where the call starts, we like to start thinking about what is it that we'll possibly be, dealing with on the scene. What kind of equipment are we going to need? We start trying to anticipate some of our needs and maybe some of our actions as well. And anytime you have someone who has an altered mental status, it's very important already to start considering possible airway embarrassment. There possibly is going to be an airway issue here, and we need to think about those sort of things. Maybe we could get some more information from the dispatch comments, maybe not, but I'm already thinking that there could be an airway problem. So the dispatcher reports that the patient has reportedly been drinking heavily this afternoon. The patient's been found unresponsive by another patron in the bathroom. We have a 30-year-old male on the floor and vomitus on the patient's face. So that's quite a bit of information. You'll learn in this chapter that alcohol is actually a respiratory depressant. So there's a problem there with the respiratory system. The patient has vomit on his face, which could mean he's going to have vomit blocking his airway. It's something that we're going to have to think about and assess once we're on the scene. So we have a lot already going on with this call, and we're not even there yet. Also, we need to know that there's body fluids there. We're going to be dealing with vomit. We're going to be dealing with somebody who could be intoxicated, could be unconscious. We don't know, but we need to prepare for that by having some eyewear, having standard precautions, gloves, and that sort of thing. All right, so how would you proceed to assess and care for this patient? All right, so here we go. And we're going to talk about respirations. Respirations are also commonly referred to as ventilations or breathing. They're used kind of as the same. However, there are true physiological differences between ventilation or breathing and various types of respiration. We can break respiration down into 4 distinct components. There's pulmonary ventilation, there's external ventilation, internal ventilation, and cellular respiration metabolism. We will talk about all 4 of those in our lecture. Physiologically, the term respiration refers to the gas exchange process that occurs between the alveoli or cells and the capillaries. So there's a gas exchange process that you learned in chapter 7 or 8 possibly, that occurs at the alveoli. Now you will always refer to those chapters throughout the rest of this book. That's why it's such an important chapters. But we're going to talk more about this gas exchange, and we're going to talk about the utilization of glucose and oxygen with metabolism as well. All right, so here we have a representation here of external and internal respirations. All right, so here we have the outside air. I'm sorry, 1 second. So let's talk about pulmonary ventilations. I like to try to jump ahead sometimes, and I don't need to do that. So pulmonary ventilations are simply ventilation or breathing. It's a mechanical process of moving air in and out of the lungs. So when we talk about a mechanical process, what we're talking about is kind of like this. The outside part of the car, right? Maybe you think about when we're talking about mechanical in this sense, we're talking about the diaphragm. All right, we're talking about muscles, external and internal intercostal muscles. We're talking about the mechanics behind breathing itself. So what happens is we have to be able to inhale. Our diaphragm has to be able to lift up. We have to be able to expand our chest. All of those are mechanics. If I have several rib fractures, I'm probably not going to want to breathe. I'm not going to want to take deep breaths. So those ribs are a mechanical piece of pulmonary ventilation. When we talk about external respiration, that's the actual gas exchange process that's going to occur between these alveoli down here and the surrounding pulmonary capillaries. The capillaries are veins, we can say veins and we can say arteries, but they're so tiny here, we call them venules and arterioles. And they lay right on top of these little sacs. They're not, you can see it here, but they're all over these sacs. And they're very close together. That allows for that gas exchange. But that's what we're talking about when we talk about external respiration, is an actual gas exchange between oxygen and carbon dioxide. Now that oxygen is going to actually diffuse from this alveoli, right? And it's going to go down here into the actual bloodstream. It happens because it's like natural, like the river flows in one direction, right? It flows one way. It doesn't normally flow backwards. You can't turn it around. That's how oxygen just diffuses out of the alveoli, because there's not a lot of oxygen in this blood that's returning from the right side of the heart. It's dirty blood. It's CO2. Okay, so oxygen is going to diffuse there. CO2 is going to do the same thing, except it's going to come up into the alveoli. Okay, and it's just like, I know a lot of you guys and ladies and all that, you drink, bottled water, and you may have a Gatorade pack or some type of flavored drink pack. And when you pour it in there, it just diffuses throughout the bottle, because that's just what it does. And before you know it, if it's a red packet that you poured in, maybe it's fruit punch, and you look at it, your bottle's halfway red before you even shake the bottle. That's the same thing that's going on here with diffusion. So and then, and so internal respiration is the gas exchange process that occurs between the cells and the systemic capillaries. So that's not pictured here. Okay, we'll get into that in a minute. But right here, what you're looking at is external respirations. Internal respiration, we'll look at that in a minute. That's when we're actually going to feed the cells of our body. We're going to take oxygenated blood and drop it off and pick up dirty blood, dirty CO2 there. That's what you're looking at here. Dirty CO2 has already been picked up. So that's internal respiration, not in this picture. Not in this picture. All right, so let's review the anatomy and physiology that you learned last chapter about the upper airway. So here we have the nasal cavity. What's the function of this upper airway? Everything in anatomy and physiology has a function. So the function here is we're going to warm the air, right? We're going to warm the air. We're going to filter the oxygen that we're breathing in, right? We're going to remove those tiny particles of dust and all that. And there's also, we use the upper airway to modulate our voice. You've heard people say that person sounds like they're singing through their nose. Well, that's what you have here. It helps with sound. Even when we come down here in a second, the vocal cords are there. That's what helps modulate our voice. But let's go back up here. So we have the nasal cavity here. Again, I told you what it does. And then we're going to break it down into the nasopharynx. Okay, so naso being nasal and pharynx meaning throat. So it's the part of the nasal cavity that's starting to come now to back here to the back of the throat. All right, and so from the nasal pharynx here we have the oral airway, the oral pharynx, again, throat. We have our tongue right here. Okay. There's three parts of this pharynx. There's the nasopharynx, the oral pharynx, and the laryngopharynx. So nasopharynx comes down, and right here is where the oral pharynx picks up and comes down. And right here, just above the vocal cords, is where the laryngopharynx is. Here you have the epiglottis. Now the epiglottis helps to keep food out of the trachea. It also assists to move food down into the esophagus. All right, and there's those vocal cords. You can't really see them, but the slide points it out there. And so then there's the larynx. Okay, so anything above this larynx is considered the upper airway. Anything below the larynx is going to be considered the lower airway. Here's the trachea, right? AKA windpipe. All right, and as you'll notice here, the trachea is in front and the esophagus is in the back. So the trachea is posterior. I'm sorry, did not mean to say it. The trachea is anterior to the esophagus. All right. Let me check my notes and see if there's anything else here. Here is the thyroid cartilage is here. Here's the thyroid gland. Covered pretty much all of that. Keep on moving on. So let's go down now. Let's go down now to the lower airways. Let's talk about the lower airway. So here's your larynx. So we're going to be south of that. You notice your trachea. It's going to split off to the right and left. This is known as the carina. That's where it splits right and left. And then we have something called the bronchi. The primary bronchi right here. And those bronchi are going to become smaller, becoming bronchioles. And so the function here is some of this is used, some of the part of the trachea here is used to bring air into the bronchioles. This trachea is made up of a lot of cartilage, so it's flexible to some extent, and they have these C-rings. And so the C-rings just wrap around the trachea with the opening to the posterior side. Here we have our lung tissue. So this is made up right here. You notice it's a smooth muscle. So smooth muscle has the ability to either become very constricted or can dilate. And we'll see that a lot of times when we talk about anaphylactic reactions. You'll cover that later. But you'll learn that smooth muscle can actually constrict, or it can become, it can dilate. The respiratory mucosa is just that. It's a lining. It's a wet lining. The respiratory epithelium is just the tissue cells that lines the trachea. Again, we're just reviewing the anatomy and physiology. Here we have the thoracic wall. We have the bronchus here. Here's our right and left lung. Here's the area known as the mediastinum. Here's your visceral pleural and your parietal pleural, and then the pleural space in the middle. Important because the visceral pleural actually is going over the lung organ itself. The parietal pleural is actually attached to the chest wall, and it has a space in between called a pleural space, or you may hear it called the potential space. Inside that potential space, we can have inflammation. So yeah, we can have inflammation build up there, or we can have air build in there. It's a potential space. The diaphragm here, major muscle of breathing, and is responsible for 70% of breathing. So a very, very important organ here. The slide doesn't show it, but it's stimulated by the phrenic nerve coming from the medulla area of the brain. It comes down, coming from the between C3 and C5 area of the cervical spine. It comes down and attaches here to the diaphragm, and it innervates, means it stimulates this diaphragm to contract. And so it's a big deal. So if you have an injury in that area of the cervical spine between C3 and C5, sometimes you see involvement of that phrenic nerve, and the diaphragm doesn't get the message to contract. So the mechanics of pulmonary ventilation, inhalation. So let's talk about it, because this is extremely important. I want you to really understand this and reach out if you don't. All right. Here we have the diaphragm. So the diaphragm is here. The diaphragm is going to contract down. We have the intercostal muscles that will follow the diaphragm. The intercostal muscles are right here. They're in between the rib cages, and they help to contract. So you have the diaphragm contracts, your intercostal muscles contract, diaphragm contracts and moves down and outward. It allows your lungs to inflate. It allows air to come in, 21% oxygen. It creates a vacuum. When we look at atmospheric pressure, 760 is normal where we're at right now. When I take a deep breath in, the atmospheric pressure in my chest cavity will change. It will become more negative. It's going to go down to 758. It's that change in that negative pressure that pulls in air, that oxygen, that 21% oxygen from the outside. It's like I said, it's a vacuum. Then after I relax and I exhale, that is going to make that chest cavity more positive. Now we're going to be around 761. All right, and what's that allow? That allows for my lungs to relax, and it allows air to be pushed back up out the trachea, and I'll be pushing out CO2. That's an important thing to know too. I'm inhaling O2, I'm exhaling CO2. It's important to understand that though, that it's that vacuum that's created, because if we end up getting if I have a stab wound to my chest, a knife blade comes in, goes in between my rib cages, it completely misses my lung. Can I still have a pneumothorax? Yes, I can. And the reason why that is because of the vacuum of pressure that's created. The hole in my chest is going to suck air in, just like the trachea does, except I can't exhale air that's trapped in my chest cavity. And that makes the chest cavity continuously become more negative, more negative, more negative, until the lung actually collapses. The lung will be forced by pressure to collapse. Perfectly healthy lung will collapse under pressure. So that is why it's important to understand how a vacuum is created and when it's created. Exhalation, we've talked about this a second ago. The lungs actually are allowed to recoil. Intercostal muscles relax along with the rib cage. The diaphragm relaxes and moves upward. It moves upward and it helps those lungs to rid that CO2. Let's talk about the mechanics of ventilation, and let's talk about the pulmonary ventilation review, control of respirations. So we know ventilation is controlled by the communications between the chemoreceptors and the brainstem, which send those impulses to the respiratory muscles. So let's talk about it. Another important thing. So here we have nervous control and respiration. Here we have the pneumotaxic center part of the brain, right here at the pons. We have the VRG and the DRG. And what happens is those chemoreceptors will read O2 or CO2. Well, what they're going to read on healthy people, hopefully like you and like me, is we breathe upon CO2. The amount of CO2 that rids our body. So if we're building up CO2, we're going to breathe faster because CO2 makes acid, and we can't have that. We have to get rid of that or it will eventually kill the cell. So our body reads CO2. The other reason why it reads CO2 is because we have a reserve. There's a little bit of a reserve in our lungs. And if we read oxygen and we breathed on just oxygen alone, then we would burn through our reserves and have nothing left when the day came that we couldn't breathe. So we read CO2 for that reason. Now, there's folks who have disease processes who chronically have high CO2 readings. Those are your COPD patients, your chronic bronchitis, chronic emphysema patients. They chronically have high levels of CO2. So high that the body can't read CO2 anymore. Then it starts to read O2. And the reading of that oxygen level is called a hypoxic drive. Now, those patients are dependent upon O2 readings only. See, we have the intercostal muscles here. The medulla oblongata is the respiratory center part of the brain. I mentioned the chemoreceptors. The chemoreceptors are found in the medulla, and these would be the central chemoreceptors. These receptors are going to read CO2 and hydrogen. You'll learn later why they read hydrogen. Hydrogen means acid. So if our body becomes too acidotic because we can't breathe, that's a problem. Our brain needs to be able to send the message to the diaphragm to contract deeper and to go faster in those cases. Hypoxia. So what is hypoxia? Okay, so hypoxia occurs when inadequate amount of oxygen is being delivered to the cells. So inadequate amount of oxygen being delivered to the cells. So it could be a mechanical piece where my chest hurts too much to take a deep breath. My diaphragm is ripped. It could be it could be from external respirations, a problem getting oxygen to the alveoli. So there's reasons why that hypoxia can occur. So they tell you that cyanosis is an indication of severe hypoxia. What is cyanosis? Well, cyanosis is that bluish color that usually comes around a person's lips when they're low on oxygen. It's a very late sign. Now, it happens to be an early sign in infants, but it's very late in adults. So inadequate amount of oxygen to the cells. Now this here looks like internal respirations. So what do we have here? So we need to walk through this real quick. We need to walk through this real quick. Let me see if I can pull up my pad. Hang on one second. Okay, we're back, and I wanted to walk through this with you guys so that you will understand this. If you don't understand gas exchange, you will be lost forever and ever. Amen. So this is the big picture. So let me kind of come down. Okay, and so let's start here at the heart, okay? All right, let's start right here at the heart. We have the right atrium here. We have the left ventricle here. And let's orient ourselves over this way now. The left atrium and the left ventricle. Now, we know that there's valves here. So let's just kind of draw those in here a little bit. Okay, so let's start up here at the right atrium. We have deoxygenated blood in the right atrium, and I'll explain why that's deoxygenated in just a second. So we're going to have that blood, it's deoxygenated, so it's blue. It's blue. It has no oxygen in it, deoxygenated. The right atrium will never, ever have oxygenated blood in it. We're going to go through the tricuspid valve. And then we're going to go down here to the left ventricle. We make our way around the left ventricle. And we're going to climb up here to the pulmonary valve and to the pulmonary arteries. Now remember, this is deoxygenated blood. We're making our way up to the alveoli, and we get here to the alveoli. And this is where diffusion occurs. Diffusion doesn't have to be hard, folks. It doesn't. Don't focus on the word. Just focus on what's happening. Okay, so deoxygenated blood's coming into the alveoli because it's just meant to. It's just meant to. It's the way it is. It'll never change. And then it processes in here. It comes out the alveoli after being oxygenated through the pulmonary veins. We have nice, crystal, clean, oxygen-filled blood. Now let's look at this for a second. Air is coming from the outside, 21%, and it's coming down the trachea through the bronchioles or bronchioli into the alveoli. This is called pulmonary ventilation breathing. We are bringing in oxygen, simple breathing. Now here, we've made that gas exchange. Now it's going to be called external respirations. External respirations. All right, let's take our really crystal clean blood coming through the pulmonary veins, and we're going to dump out here into this left atrium. Okay, so we are in the left atrium. All right, we're going to come through a valve here. It's the bicuspid valve into the left ventricle. We're going to go through the aortic valve, okay, and out the aorta. And this is important to know for later. It's that curve. You see how this left ventricle, it's pumping uphill and around a curve. So it's accounting for that force that it needs. Okay? It's when you get into congestive heart failure, pulmonary edema, where this is the problem. Then it's pumping at such a force. Oh my gosh. It comes around this corner. What's it doing now? It's going downhill at a velocity that's going to overcome. It's going to overcome, and something's got to give. And it's the watery plasma that gives. And that is called afterload. But let's go down here. Let's go down. We're coming downhill, straight downhill. Gravity's pulling us. We're making this little small curve, and here we are. We are at the cells. We have to feed the cells. If they don't get oxygen, they're going to die. This could be a liver cell, kidney cell, pancreatic cell, you name it. It could anywhere. It could be that cell. We're going to drop off some oxygen. We're going to drop off some oxygen. Why? Because it's just meant to happen. It's got to happen. And then what are we going to do? We got to take out the trash. Come over here. Let's take out the trash. Let's take out the CO2. Because this is dirty now. We've resupplied. But one of the functions of blood is to deliver oxygen and remove waste, along with temperature control. That's it. Okay? We're going to remove the waste now. We're removing the waste, and what do we have? It's dirty CO2 blood. It's going to come through here. It's going to go back up. My pen is not working really good. And then we're going to dump off back into the right atrium and do it all over again. This is called, down here at the bottom, feeding the cells, internal respiration. Okay, internal respiration. I think of it as just, I'm feeding the internal organs. That's it. That's breathing. That's breathing, guys. Let's go back to the slideshow. Let's go back to those slideshow. Okay, so that's it. So inadequate amount of oxygen to the cells, hypoxia. Okay. So let's talk about signs of mild to moderate hypoxia. And we're going to talk about these signs. And I need you to really, really, really focus on this, okay? Because we're talking about mild to moderate hypoxia. There's a difference in mild to moderate, and then talking about respiratory failure. Huge. All right. So this is a person who's not in respiratory failure. This is a person that could be close, but they're not there yet. So tachypnea, the respiratory rate is fast. Dyspnea, that's a medical word for trouble breathing. Pale and cool. Well, why? Why? I understand, fast breathing, difficulty in breathing. Well, how come they're pale and cool? Remember, there is a gas exchange that needs to take place so that the internal cells get fed. If for some reason there's not enough gas to make a gas exchange, or there's not enough blood to take the oxygen and CO2, you're going to show it in your skin color and temp. Okay? Clammy skin, the same thing. Anytime you have somebody who's pale, cool, and clammy, that means they're hypoperfusing. They are low perfusing. They're not able to either get enough air in or circulate enough blood to make a gas exchange. Tachycardia, fast heart rate. Restless, agitation. Where does that come from? Well, up here in the brain, that's where we're happy, we're sad, all that happens up here. If you're lacking oxygen, then your mental status is going to be off. You could be angry, you could be restless, you could be agitated, all of those things. If the brain's not being perfused. Now, when I say perfused, I mean perfused either with oxygen or blood or both. Okay? And then the patient disoriented and confused. So everything relies on your mental status, relies on, are we being perfused? And if you see these signs, that tells you that this patient, their diaphragm's working great. Mechanically, they're doing it. No problem. We got to decide, is it because they're not getting enough air in? Is that the problem? Are they asthmatic, COPD, emphysema? Is that it? Is it just because we can't get enough oxygen down to the alveoli? Or is it a problem we don't have enough blood to circulate through? That's what we're talking about. Okay, severe hypoxia. Okay, severe hypoxia. This is somebody that's close to respiratory failure. Let's look at this person. You see how she's sitting? This is called a tripod position. Okay, she's in a tripod position. She's got her arms, her hands at her knees, and she's probably pushing on them to help her internal intercostals contract. And then here's a new one, to help those external intercostals to move air out of her lungs. So again, tachypnea, okay? Fast breathing. Dyspnea, difficulty in breathing. Cyanosis. Cyanosis is a late sign, but we would see maybe some light bluish, grayish color around the lips. Tachycardia. So we're going to have a fast heart rate. There's a reason behind that. The brain is releasing epi and norepi. Okay, you probably learned a little bit about that in 7 and 8. Okay, and so it's those two things that are causing the heart to beat faster. Your body does that to try to have those epi and norepi actually try to make that smooth muscle that we talked about earlier to dilate. Confusion, head bobbing. This is when a person is getting so tired from breathing, they're about to give up. They're about to give up. Head bobbing is a very, very bad sign. Slow reaction time. They're slow reacting because their brain's not being perfused with oxygen. Okay, you got to have perfusion. You got to drop off oxygen, and what else? Pick up the garbage. Pick up the CO2. Right? And then altered mental status. Okay, alveolar capillary exchange, external respirations. Okay, so here we have blood from the right side of the heart enters the pulmonary capillaries. All right, and so anything from the right side of the heart is what? Is it oxygenated or deoxygenated? Deoxygenated. Right side, trash. Trash, 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 and a little more trash. All right. Deoxygenated blood has low levels of O2 and high levels of CO2. That makes sense because what did we pick up earlier? We dropped off oxygen and we picked up CO2. All right, so here's your capillary. It's blue representing no O2, and over here is red representing O2. The reason why that red thing is because of hemoglobin. Hemoglobin gives your blood that reddish tint. But hemoglobin also carries oxygen, and so that's where the color thing comes from. Now, let's look at this. Oxygenated blood has high levels of O2 and has a low levels of CO2. Makes sense. Diffusion. What happened was we sent that CO2 into the alveoli. We sent it in there, and we picked up O2. So now oxygenated blood has high levels of oxygen and low levels of CO2. Blood's going to leave the capillaries, transported back to the left side of the heart by the pulmonary veins. Okay, left side of the heart. Left side of the heart, oxygenated or deoxygenated? Oxygenated all day long. Left side of the heart's really good and clean. Right side of the heart's trash. Internal respirations. Okay, so this is where now we've left the left side of the heart. We've came up through the aortic valve into the aorta, and we've came out oxygenated blood in hand. Oxygenated blood in hand. And what's going to happen here? Well, here we have that we just came through the aortic artery. We're still there, coming out around the corner, and here we are. So we have low levels of CO2, high levels of O2. What are we going to do? We're going to drop off. All right, we're dropping off the O2 to the cells. See? Here's a cell, gets O2. You need some O2? We got it. Hey, you want some O2? We got it. Hey, can you do me a favor? Give me your trash. I need your trash. I need your trash, and I need your trash. All right, I got everybody's trash. What can I do now? Now I'm going to go out back to which side of the heart? What is the right side of the heart? Exactly, trash. So you're going back to the right side of the heart with what? With high levels of CO2 now and low levels of O2. Okay, so let's talk about it. Let's talk about causes of disruption. So there's mechanical, there's disease or obstructions, right? So mechanical process, okay? So this is everything that helps you to breathe minus a gas exchange. So your diaphragm, your intercostal muscles, your rib cage, all that stuff, mechanical. That is what's going to help. That's what helps you to take care of the mechanical process of breathing. Diseases. Let's talk about diseases. What are some diseases that you're aware of that can cause problems in breathing? How about pneumonia? Okay. Makes sense. A little pneumonia. COPD. Asthma. All those are disease processes. And what are they doing? Well, one or two things here. All right, so COPD is going to affect these alveoli. Going to make fewer of them. Okay. Pneumonia, it's a bacterial infection most of the time. And we see a lot of viral now with COVID. But pneumonia is going to cause problems with bronchial constriction. So is asthma. Asthma is going to cause major problems with bronchial constriction. What about obstructions? So if you can't get air from down your trachea into your bronchioles, that's going to be an obstruction. Okay? And there's other obstructions we'll talk about. All right, so airways in kids, we know from last chapter that we know that the tongue is proportionally larger in a child, and there is more narrow of a glottic opening. Okay. We know that the child's trachea is more flexible because that cartilage hasn't gotten really, hard yet. Airway functions. All right, general functions, mental status changes. I don't normally like to read the slide, but I can't help it in this chapter because everything seems to be so important. So the function of the airway is this. We got to get air. We got to get air out here in there. Okay, it's pretty simple. We got a kid here who's been burned. Okay, so we possibly have obstructions. Remember, this is where everybody thinks, oh, the function of the upper airway, God, I got that. It's easy. That's, it's going to be warming the air and filtering. Well, and then everybody gets here and forgets it because it's so easy. But no, seriously, if this kid's airway is burned, am I going to be able to moisten air? Am I going to be able to filter? Nope, I'm not. All right, what about back here? All right, remember we have the nasopharynx, we have the oropharynx. All of that could be swollen. Okay, all of that could be swollen. Because burns cause edema. You'll talk about that later. Of like inflammatory response. So we got a problem. We have an obstruction. This person's not bleeding to death. We're just going to have a problem getting air circulated, oxygen circulated to the alveoli. And then we're going to have all that trash building up. All that CO2 is going to build up. We can't breathe it out. All right. So these are sounds that people make that are abnormal, that need our attention. So snoring, okay, crowing, gurgling, and stridor. Snoring. So anytime you have somebody who has snoring respirations, it's probably because their tongue is obstructing their airway. we need to do a head tilt chin lift unless there's trauma involved. Then we need to do a modified jaw thrust. Crowing. Ha, ha, like that. Sounds like a crow. Gurgling. Guys, I know this is going to happen. Instructor Riggs knows this is going to happen. Anytime you have somebody gurgling, that means they probably have vomitus or blood in the back of their airway. They need to be suctioned immediately. Okay? I used to say, it doesn't matter the scenario I'll give. If I told somebody just got run over by an airplane, and gave them whatever, but the word gurgling is in there. Suction their airway. Look for suction the airway. If you see gurgling and you don't see suction in the airway, go back and read it again. You probably missed it. And then stridor. What's stridor? Well, stridor is when right down here you have your trachea and you have this glottic opening and it's becoming very narrow. See how narrow it's becoming and air is squeaking by. It sounds like a whistling noise. Stridor is an ominous sound. It means the upper airway is closing off. And once the upper airway is closed off from like an allergic reaction, something like that, it's hard to ventilate that patient. So what are we going to do? What are we going to do? Well, we need to open the mouth. We need to visualize the mouth, especially with anybody who's altered or unconscious. You have to open their mouth to assess their airway. Got to. Here's your cross finger technique. You'll probably do that in lab. Head tilt chin lift maneuver, just like this. As long as there's no trauma, it's great. And you got to be careful because once you do open it, see how this epiglottis here is blocking the airway? Sorry. Once you open it, you have to keep it open. Head tilt chin lift. You do it on a kid too. Just like that. You'll do it in lab. Jaw thrust maneuver. This is for trauma patients. We're not lifting their neck back. We're pushing their jaw, lower mandible forward. And you'll do that in lab. Okay. I'm going to go through these because you will do these in lab. All right. This is called the recovery position. Somebody who's unconscious without trauma, you could put them on their left side or their right side. It's kind of, just be careful because if it's a trauma patient, they have to go on a backboard and turned on the backboard. You put seat belts on and all that, but you'll do it in lab. I want to cover theory in this lecture. All right, standard precautions. This young man has standard precautions. He's going to suction somebody's airway. So what does he have? So he has his eye shield, his face mask, gloves. Those are standard precautions for suctioning. Standard precautions for wrapping a wound might just be gloves. But when you suction someone's airway, standard precautions is this. That is how it works. Suction equipment. So there's fixed and portable suction catheters. You'll do that in lab. All right, so here we go. We've got somebody getting suctioned here. You'll do this in lab as well. Stand by. Let me see. When you're suctioning no longer than 15 seconds, okay, you need to, while you're suctioning, while you're suctioning, monitor that pulse rate. And if you have bradycardia where that pulse rate drops, stop suctioning and begin ventilating. You'll talk about that in lab. This oropharyngeal airway is designed with simplicity, but has saved so many lives. It goes in and it keeps the tongue, from blocking the airway. This is used with patients who are completely unconscious without a gag reflex. If you go to put one in and somebody's gagging, take it out. The nasopharyngeal airway is different. It can be used with patients who are conscious or semi-conscious. It doesn't necessarily cause a gag reflex. It goes in through one of the nasal nares, either right or left. Okay. And you see this? It just goes right into through the nasopharynx and helps keep the airway open. You'll talk about how to measure it and all that in lab. All this will be done in lab. Let's talk about minute volume. This is what stuff I need to talk about. So what is minute volume? So you have to understand the relationship between respiratory rate and tidal volume, and need to understand the amount of air that's actually reaching the alveoli. Guys, it's huge. You got to know this. So let's talk about it. What's the definition of minute volume? So minute volume is going to equal the depth. When we talk about depth of respirations, we're talking about the tidal volume. Tidal volume, a normal tidal volume is about 500 milliliters. We're going to multiply that by the rate. Rate meaning the respiratory rate per minute. Okay, that is your minute volume. If you have a decrease in tidal volume or rate, then we could have problems. Alveolar ventilation. So this is going to be the amount of air that reaches the alveoli. Okay, the amount of air that reaches the alveoli. So minute volume equals volume times rate. So here's an example. Minute volume, 200 milliliters of tidal volume multiplied by 12 breaths per minute. Now I said 500 milliliters is a normal tidal volume. So we're way less than 500 here. Minute volume in this case will be 2,400 milliliters per minute. 150 milliliters will be filled with the dead space. That means dead space, like you're going to lose air coming through the nasopharynx down to through your oral pharynx, all the way down through the bronchi. So you're going to lose some of that air. You can't just suck all that air in. So we have to add that in too, and I'll show you. Whoops, hang on, maybe I won't. All right, so of the 200 milliliters of air taken in with each breath, 150 milliliters will be filled with dead space, leaving only 50 milliliters, 50, to reach the alveoli for gas exchange, even though the patient's breathing 12 times per minute. So that's what, let's talk about it. So never go on respiratory rate alone. You will fail every time. If you assume that 24 breaths per minute is good and the patient's not in failure, you will be wrong. If you think 10 breaths per minute and the patient's not in failure, you will be wrong. Respiratory rate is designed to get your attention. Nothing more and nothing less. Get your attention. It's not the be all do all. It's not going to decide whether your patient's in respiratory failure or not. You must have at least 1 inch of chest rise. 1 inch. Anything less than 1 inch of chest rise, you're in failure. So how do we say this usually? Excuse me. So you need to be looking for keywords. All right, so the word inadequate. I could say the patient's breathing 26 times per minute and inadequate. That means they're in failure. That means their chest rise is less than 1 inch. All right. Inadequate is one word I can think of. What's some of the other words? It's been a while since I had to do this. But inadequate's one of the big ones. Compromised sometimes, but that's what you need to listen to. So, but what if? Because every EMT student in the world loves to do what if. So let's do a what if. Let's do it. Well, Instructor Morris, if they tell me the patient's breathing 40 times per minute and that's all I get, what do I do then? Then it's failure. If all I've got is one number and that's it, nothing else to describe the breathing, then I'm with you. I'll join your team. They're in failure. Other than that, usually it's 40 times per minute and inadequate, 40 times per minute and labored. Okay, labored. Well, labored doesn't necessarily mean that the patient's in failure. It means they're labored. So you need to look for other signs and symptoms. But at the end of the day, you're looking for something that would suggest that you have less than 1 inch of chest rise and fall. And that's just that. So how are we going to assess to make sure this person is adequately breathing? We're going to look. Look, what are you looking for? Just what I said. Chest rise and fall. What did I say it needs to be? Greater than 1 inch. Greater than 1 inch. Has to be. What are you going to be listening for? Crowing, stridor, wheezing, stuff like that. Feeling, feel that chest and see if you can feel it rising 1 inch or not. And then you're going to listen, auscultate, which means listening to lung sounds for all of that I just covered. Adequate breathing. Rate, rhythm, quality, and depth. Rate is one part of it. Rhythm's one part of it. Quality is a big part, so is depth. So rate is an attention getter. So is rhythm. The quality, inadequate, is usually the word you'll see a lot. Bag them. And then depth, less than 1 inch, bag them. That's failure. Accessory muscle use is something that we're looking for. Remember that? Let me see if I can back up. So you have muscles in between the rib cages. If those rib cages are expanding and you can see them going up and down, that is accessory muscle use. Remember the head bobbing thing. All right, so all of that. So inadequate breathing. This is a patient who's working harder than normal to breathe. So they're inadequate. Inadequate. Bag them. Bag them. I'm just telling you. Probably going to be less than 1 inch. I don't know what the respiratory rate is, but inadequate in my term means it sucks. Bag them. Patient with inadequate alveolar ventilations and respiratory failure. Yep, they are. Results and causes. There's lots of causes, but the result will be death if you do not treat these patients appropriately at your level. I'm a paramedic. I have all these advanced techniques I can do, but I will kill people all day long if I can't recognize the difference between respiratory failure and respiratory distress. So signs of inadequate breathing we talked about. Rate, rhythm, quality, depth. The rate's either too fast or too slow, right? That's what it comes down to. Too fast, man. Too fast, oh Lord, here we go. Too fast or too slow. right? And is it too slow to be in failure? Is it too fast to be in failure? That's going to come down to depth. What's the quality like? Breath sounds that are decreased or absent indicate inadequate volume of air. So absent breath sounds is a bad sign. If you're like, I can't hear breath sounds, it's probably not because you're doing something wrong. It's probably they just don't have them. They're not breathing well enough to be able to hear them. This guy, look how tripod he is. But look at this here. You got the cigarette ashtray there. It's probably emphysema, COPD. Making the decision to ventilate or not. Huge. Both respiratory rate and tidal volume must be adequate. Okay? But what happens is I'm COPD and I'm breathing 26 times per minute and I'm a little bit labored. Or I'm moderately labored. I'm not in failure. I have a high respiratory rate. I'm not in failure. Mechanicals, guy. Mechanical breathing. Is that diaphragm coming up enough to where I'm getting 1 inch chest rise or not? That's where it lies. All right, so here's a little thing. Adequate respiratory rate plus adequate tidal volume equals adequate breathing. So attention getter is your respiratory rate. Tidal volume is your ultimate decision whether you're bagging or not. So let's talk about the artificial ventilation. So artificially ventilating means we're going to use a device to ventilate this patient. Positive pressure ventilation, PPV, is the number one thing we start out with. This is basic to advanced. Everybody starts bagging a patient like this. PPV. And if we're bagging, we're gagging. Meaning we're going to try an oral airway. If they gag, we're going to pull it out and we'll insert a nasal pharyngeal airway. Differences between normal spontaneous ventilations and positive pressure ventilations. So a patient who's breathing spontaneously is breathing on their own. So what we'll do is, let's say you're breathing 8 times per minute and inadequate. So we're going to use positive pressure ventilation to bag you. And we will bag you over, let's say you're breathing 8 times per minute inadequate, meaning you're less than 1 inch of chest rise. We're going to bag you 12 times per minute. And when we're bagging you, your chest will rise at least 1 inch. All right. I'm going to let Instructor Riggs cover CPAP with you guys because she might have something special that she wants you to know about. I'm also going to let her cover the non-rebreathers and the other devices. So let's do our follow-up from our case study. Scene size up. So we get there. The bartender reports that the patient's been drinking all morning and all afternoon. He's 30 years old. He's lying in a puddle of vomit. What are you thinking? I'm thinking there could be an airway problem. I see a puddle of vomit. I'm worried. No one knows this person. They've never seen him before, as usual. All right, so we're going to do inline C-spine stabilization because we don't know what happened. He could have gotten into a fight. He could have a cervical spine injury. We don't know. He has no gag reflex, so can we put an oral airway in? Yes, we can. This guy's breathing 6 times per minute. He's breathing, 6 per minute, Ventilation's at respiratory rate 6 per minute. Ventilation's at 10 per minute. Okay. Well, all right. So there's no signs of head or neck trauma. The patient starts vomiting en route. We suction him. We transport the patient over to the ER staff. I'm trying to figure out this respiratory rate. 6 per. Okay, so he's breathing 6 times per minute. So what we're going to do is we'll put the oral airway in, and we're going to ventilate him with at least 1 inch of chest rise at 10 breaths per minute. All right, guys. That is it. All right, so here's your video. Study the video. Get with Instructor Riggs when you get back to class. Good luck on your good luck in your studying, and good luck on your exams.